All right, so pain in the butt, abdominal stuff, and all that stuff. They're oops, do have a little bit change the disclaimer around a little bit, just from the aspect of school versus life. In school, we're taught lessons, take a test. In life, we're given the test, and that teaches you the lessons. So I was trying to actually find something funny about all that stuff. Like everything else, then anatomy phys. The GI system pretty much is from mouth to anus, depending on most of the organ systems of the GI are in the abdomen, and that's where we'll be diving into in a little bit. Everything digestion begins in the mouth, chewing process called mastication, and then we do start having some other digestive properties going on inside the mouth. Usually, it's most of your um, glucose type foods, your starch, all that stuff is really broken down, and you also do have absorption in the mouth, i.e., your oral glucose. Okay, that's why we give it that way for those type patients, because you can absorb some of the sugar and all that stuff. It's broken down and then absorbed in the mouth and then down the rest of the the side of it. Digestion, pretty much it's the parasympathetic. This is your rest and digest. Remember that? Okay, so it's the predominantly coming from the vagus nerve down. Um, there's also multiple other hormones, pepsin, cytokines, and all that stuff that help with the motility system. I'm really not going to talk much about that. The esophagus or esophagus, depending on who you talk to, it's usually a collapsed um, organ system, but then from there it does allow for movement. And what is the movement term called going down the esophagus? Swallowing. But then from there, what's the forward propulsion of food is called, starts with the P, peristalsis. Okay. One of the problems, though, of course, when we are potentially the airway, BVMing, and all that stuff, since it is a hollow organ, there's nothing that really stops air going into the esophagus, which goes down into the stomach, which then goes down into the large intestines, our small intestines, large intestines. Okay, so that's how we get our gastric distension and all that stuff with positive ventilation. Peristalsis, and then from there. Down at the bottom of the esophagus is where the portal vein is kind of sort of intertwined along with the vagus nerve. There's two branches of the vagus down in that, but don't worry about that. In the portal vein, the purpose of that, when we talk a little bit later, was cirrhosis and the bleeding and all that stuff is because of that portal vein system, or it's called anastomosis. It's a low pressure system that can actually back upwards from the liver, which expands the blood vessels around the lower esophagus. Okay, so what happens when those blood vessels break? So cirrhotic patients, liver failure, blood vessels, they're known to have problems with. Okay. So the blood vessels break. What do? They bleed. Okay. So this is your esophageal varices stuff. Okay. They throw up the blood and they can die from it. All right. We'll talk about more like that in a little bit. Um, food goes through the cardiac sphincter. Unlike the pyloric sphincter, the cardiac is not a true sphincter where it's a muscle. The cardiac sphincter is actually really more along the diaphragm, or it's the diaphragm that kind of sort of holds and holds it together and pulls it together. With that, if the diaphragm kind of apart and moves, the esophagus, the stomach, and all that stuff can go upwards, and that's where we get hiatal hernia. And that's also the aspect of with people with reflux, GERD, and all that stuff. That's where they hit the feeling of having chest pain for that exact same reason. Because to the stomach, there's what's called proteases, which are the digestive enzymes, and then hydrochloric acid. The hydrochloric acid drops the pH down, which allows for the proteases to work. But then from there, the hydrochloric acid, that's one of the immune system, part of the immune system of controlling the bacteria. All of that's kind of sort of tossed around into the stomach, and then ultimately it goes away from quote unquote food to a product called chyme. And the chyme then goes into the small bowels. Questions thus far? Anatomy review. All right. The other important factor for the stomach and all that stuff is the intrinsic factor here, which is released from one of the two different types of cells in the stomach. The intrinsic factor is with vitamin B12. All right. It binds to B12, which in turn allows for it to be absorbed into the small intestine. All right. The problem here is some of your bariatric surgeries, okay, they kind of sort of take out the top part of the stomach when that's where the intrinsic factor is produced. So we have a lot of patients that have the potential of having B12 deficiency, and B12 is part of the nervous system and also blood production. So think about and all that stuff. It's also your alcoholics. They have problems with this too. Or I should say drunks. Alcoholics quit and go to meetings. GI systems, again, the whole purpose is to absorb the digested food. Duodenum is connected to the liver, gallbladder, and pancreas. Whole bunch of different ducts and all that stuff. And then the pancreas, the whole purpose of that is it's the major thing of releasing enzymes to help break down some of the protein and some of the fat, and then also it helps neutralize the acid that's coming into the small intestine. If not, it would burn all the way down and go from there. Small intestines, three parts, 90% of absorption, duodenum, jejunum, and ileum. The duodenum is this little first part here from the stomach coming down, and then you have at the ligaments of Treitz all the way down till almost to the very end is the jejunum, and then the terminal part is the ileum, which attaches to the cecum, and that's where the appendix is. We'll show that in a little bit. Pancreas here looks like a football. The tail is nestled into the spleen. The head is actually, the duodenum is buried through the head of the pancreas. So a lot of people that have pancreatic cancer, which we won't talk that much about, a lot of times they talk about the duodenum and all that stuff. The gallbladder or the bile duct goes through the pancreas. So again, with the pancreatic cancer, they take all of this part out through what's called a Whipple procedure. Liver produces bile. The other portion of it is detoxifying drugs. That's really the good thing. You can live with about a quarter of your liver before we start really dying and all that stuff. The liver is the only organ in the body that actually cut it in half, as long as you have blood supply and transplant it, and it will grow back. So it's a very remarkable aspect. What's the other major thing that's the liver? What else does besides the vitamins and minerals, what else does the liver store that is really important for us? Fat, some part, okay. Something else. Diabetics need it, okay. Doesn't store it, and it's produced in the pancreas, but something that the insulin tells the liver to break down. Glucose through glycogen and all that stuff. So you basically have that the glycogen is broken down into glucose, and then from there allows us to increase our sugar. So patients that have liver Okay, they don't have that. Thereby, if you give them different types of medications to help increase the glucose, it doesn't work. All right, gallbladder. The only real purpose of the gallbladder is to store the bile, which in turns it gets emptied out. So the liver produces the bile, sticks it in the gallbladder, and then anytime you have fatty foods, um, pushed out. And the whole purpose of the bile is to what's called emulsification of the fat, break it down into little smaller pieces. And when we know that smaller pieces are more easily broken down and all that stuff. Pancreas, 6 inch, sits across the back of the peritoneum and all that stuff. On the right side, again, attached into the duodenum and all that stuff, tails into the spleen. Um, and its really purpose is it has two different things. One's exocrine, which is all of the digestive enzymes, and then the endocrine system, or going back when we gave that talk a year ago, with the insulin and then the glucagon. Um, made a mistake. Insulin builds up on the previous two slides. Glucagon is the one that tells the glycogen stores to be broken down. All right. And glucagon is one of the medications that in the future I'm going to do a study on with EMTs to be able to give intranasally to see if we can test and all that stuff. Because it's not one of your medications that you can give but as an advanced EMT. EMTs cannot give intranasal glucagon. Yeah. Yep. It's no worse than Narcan up the nose. Well, I mean, if these people have a sugar of 15 and they're unconscious, colon, large intestine. The whole purpose of the colon is really to absorb the majority of the colon from the cecum on up over to the descending colon is really to absorb water. And then the last portion of it, the sigmoid colon, is a storage for feces. And then the anus or the all the anal and all that stuff, this is the terminal portion of the GI system. Absorb water, do have some bacterial digestion occurs, and they say it can take anywhere from 8 to 72 hours after you eat food to go from the mouth to the anus, depending on what it is. Blood vessels, there's a whole bunch of different things in here, depending on which, basically every organ has at least two blood supply coming to it. Not going to really bore you with all that stuff. But the big thing to draw a conclusion on is the aorta in the inferior vena cava goes straight through all the abdomen. Portion right here is called the bifurcation, and that's the belly button. Okay, so couple things with this. Of course, if patients are complaining of abdominal pain around the umbilicus and all that stuff, elderly patients, things to think AAAs or the abdominal aortic aneurysms. All right. And with pregnant females, why is that so important? Why is this region so important? Okay. Baby lays on it at what age or what station? Second trimester. What part of second trimester? So 20 weeks. All right. 20 weeks is that magical numbers. That's when the uterus is big enough that it can actually start sitting on your aorta and the inferior vena cavas. Okay, that's why after 20 weeks we put them in the left labial cubitus position so that they don't compress that and develop IVC syndrome. And we'll be doing pregnancy again in the future. Whole bunch of blood vessels. Again, from the aspect of the hepatic veins up around the esophagus, they kind of sort of attach there. along with blood supply coming from the esophagus down, and that's where you get the portal, what's called the portal naval anastomosis. And then down in the rectum region, it's the same thing. You have blood supply around the anus, along with some of the blood supply from the legs going up, and you have a anastomosis, naval anastomosis system here. I mean, that's the majority of the reasons why patients have hemorrhoids with liver failure. Again, these are low pressure systems that allow for the blood vessels to expand open, and then from there burst and have problems and all that stuff. Can't find really many good funny slides with digestive system. All right. Any questions? Anatomy. Good. Okay. We all need it. All right. So from here, what we'll do for the next little bit is just talk about acute abdomen, and then we'll get into the breakdown of differences between inflammatory versus your infectious versus obstruction versus bleeding. That's kind of sort of where the majority of the bulk of the rest of the slides will be. And then that will be a little bit of pediatrics and traumas and all that stuff. So yes, we'll make sure that you get a little bit more than the other day. General purpose, again, acute abdomen is just the presence of signs and symptoms of inflammation. Okay, itis. Yes. Anytime you see itis on the end of something, diverticulitis, peritonitis, your cholelithitis, inflammation of or irritation of, pancreatitis again. So in the hospital, the pre-hospital, I don't really care if you guys can come up with the problem. All right. What you really need to make sure is, can you diagnose it, or can you see that this is acute abdomen, and then figure, do you need to stay or play or let them go? Is this a sick or not sick patient? Which is one of my talks at the Partners for Life. Different causes: inflammation, blockage, swelling. You can have stretching of organs, stretching of the itself, blocking of the duct, gallbladder, or blocking the common bile duct, blocking Stenson's duct, which is the duct from the pancreas into the intestines and all that stuff. Or do we, knock out mesenteric in older patients with atrial fibrillation and knock off the blood supply to the abdomen, and now they basically have their whole GI system, crash and burn. Visceral pain is just a organ. It's the all the pain receptors going into the organs. So we have the visceral, somatic, and then referred are your three different types of pains. So visceral is usually your organ pain. Pinpoint, you can kind of sort of say, yeah, it hurts right upper quadrant. Okay, what's in the right upper quadrant? Liver and gallbladder, head of the pancreas, intestines, kidneys. Okay, so, and we'll talk about all that stuff a little bit. So you can kind of sort of say, that they know exactly what it is, and it's a little bit of crampy, colicky. The pain comes and goes, and then they have some other signs and symptoms of cardia and all that stuff. Versus the somatic, this is more of irritation of the peritoneum. It's just a generalized. It hurts all over. You know, how many have had that little, 5-year-old kid going, yeah, it hurts all over. Okay, you touch everywhere, and then it goes from there. And then it's constant moving, coughing, and all that stuff. And then the referred is the radiation pain. This is the patients that have, in a trauma, they have a spleen rupture and they're complaining of left shoulder pain. Your MIs that are, the females, they complain of abdominal pain, but they're really having a myocardial infarction, the epigastric pain and all that stuff. Testicular torsion referred with abdominal pain. Even strep throat in kids can have referred pain into the abdomen and all that stuff. All right. So things to ask and what to do, how we're looking at things. So of course, history, got to know your organs, where things are located. Okay. If you don't know that, guess what? Got to go back and study. That's the only way that we can really come up and make an appropriate assessment and all that stuff. Was it gradual? Was it sudden? Did you get shot? You know, do they have a perforation, anything like that? How does it feel? Is it a steady cramping, or is it steady pain? Is it crampy pain? Sharp shooting, all that stuff. From there, does it go in? All right, right shoulder again, the or the liver, gallbladder, and all that stuff. Flank, are they having flank pain that's going around into the testicle? That's a telltale sign with the kidneys, the ureter. Do they have kidney stones or something like that? Pains and locations and all that stuff. Usually, the most part, they're the shoulders, the liver, the liver, gallbladder, and all that stuff. The other shoulder with the spleen, pancreas, because the tips and all that stuff. And a lot of it is because of how we were in embryo. All the nerves kind of sort of stretched and expanded and all that stuff. Other things to ask about duration, okay, nausea, vomiting, coffee. Okay, so coffee ground emesis is what? Okay, so from there, the hematochezia. What's the term hematochezia? Or melena. So hematochezia is bright red blood from the rectum, okay, or is that black tarry stools. So any of the urinary problems, color, bowel movements, appearance, the melena or hematochezia, and then from there, it's not always the aspect of what does the diarrhea or look like. Ask how frequency if they're having diarrhea. Is it watery? The consistency. Like a lot of that stuff can take into consideration. Females always ask about their last menstrual period, abdominal bleeding. Okay. So again going back to the OBGYN, abdominal pain with vaginal bleeding is okay. Miscarriage or until proven otherwise, it is a GYN. Ectopic pregnancy until proven otherwise. All right. So just to reiterate, signs and symptoms: guarding. Okay, they don't want you to touch their belly at all. Rapid shallow breathing, pains, any hypertension, tachycardia, all the other signs and symptoms. Do they feel constipated, bloody stools, and go from there. So on the assessment side of things, we're going to look at BSI seen safe, sick not sick, kind of sort of do your focused exam, and then look at the detailed overall assessment and all that stuff. So on your guys' guidelines for abdominal pain, again, history, kind of sort of go through all that stuff, any of the signs and symptoms: diarrhea, dysuria, constipation, bleeding, pregnancy, associated symptoms, and then the whole laundry list of differential. It can be massive depending on locations and all that stuff. NPO, hypertension, rescue guard, which you guys do have the spring here. And then from there, if they're over 40, they should get an EKG. All right. Again, if there's, unfortunately, I've seen even some late 20s, early 30-year-olds having MIs with complaint of abdominal pain stuff. So it's not always a good aspect. From the advanced EMTs and paramedics, you'll be able to do a little bit more. Are they having acute abdominal aneurysm? If they do that, then of course they go down the acute abdominal aneurysm guidelines, which is dropping the blood pressure. Signs of hypertension, giving IV/IO access, giving fluids. Are they vomiting? Oral Zofran for advanced EMTs and all that stuff. Medics can give their Zofran and Phenergan, and then pain control and go from there. Physical exam, of course, look at general appearance. Are they laying still? Are they rolling around? Are they walking? Jumping up and down. That's the last telltale signs for kids. If they have belly pain, what I'll do is I'll actually have them jump up and down. If they jump up and down, I pretty much know that there's not much going on for them. If you get because the kids won't fake it. Okay, if they won't jump up and down, there's usually something going on. Distension, ecchymosis around the umbilicus or flanks, which is colon signs or Gray Turner, which we'll see that in a little bit. Tachycardia, shallow breathing, which is another telltale sign for peritonitis, and then any of the postural changes and signs and symptoms of shock. Secondary assessment, okay. Sometimes you have to have them flex their knees, looking at striae. Okay, these are your striae, all the stretch marks and all that stuff. Not just in females pregnant and all that stuff, or previously pregnant, obese. Also, what other patient population will have the striae? Bueller, Bueller. Bariatrics, the obese, yeah. People that have liver cirrhosis, they get a lot of the striae. So is it asymmetric tumors? Nothing kind of sort of funny when you're sitting there watching their belly and one side of their the abdomen gets protruded out and then goes back in as they taking in deep breaths and all that stuff. And then any of the shapes of the abdomen. Is it scaphoid? Is it the um, flat abdomen and all that stuff? Protuberance, weight gains, ascites, pregnancy, of course, or any of your organ enlargements. Um, this is a bad sign. Right? Bowel sounds. If you actually listen to bowel sounds, great. They are, for the most part, don't give much information. My old surgical attending, he was like, they don't really do much for us. This thing is just really the aspect if you have absent bowel sounds with ileus or peritonitis. Borborygmi, I always like that term. I can still remember when I was nursing, that was the first time I ever heard of borborygmi, which is that you hear the gurgling sound and your friend's stomach is gurgling, you hear it. That's the borborygmi. And trauma not much value again for auscultations. But we do want to get into the process of do want to get into the process though of percussing and then the palpations. All right. So percussing is any of your tympanic. Doesn't matter where you start. You just need to start. And again, it's your own systematic way and all that stuff. You should the left upper and right upper should be a little bit duller. Okay. Why should the left upper and right upper quadrants be a little bit duller? Correct. All right. So you got the liver there. On the left side, you got the spleen. You got some of the intestine, the pancreas, and all that stuff. So from that aspect, it's really you don't get that nice, drum beat that you can have in the lower abdomen, all that stuff. Palpate. All right. Wear your gloves. Wear your gloves. Wear your gloves. Warm your hands, kind of sort of have the patient that they can bend their knees, and then start furthest away from the pain, and then move towards the pain and all that stuff. Other aspect is you're trying to indent at about 2 to 4 inches. You're trying to feel it for what? Distension. Okay. Masses, fecal material. Okay. all that stuff that you're trying to push through and all that. Gotta know what's in your quadrants. So right upper is your liver, gallbladder, and part of the large and small intestines. Right lower is your appendix, small intestine, fallopian tubes, and ovaries in the females. Of course, left, and then again, small and large intestine, ovary, and a fallopian tube. And then your left upper quadrant, your stomach, spleen, pancreas, part of large intestines, part of the small intestines are there too. All right, and then the diaphragm kind of sort of splits the cavities. Rebound. All right, this is where you push down into the belly and then let go, and then they have pain. They can sometimes jump off the bed. That's your quote unquote rebound tenderness. The other one that I'm actually doing is a heel tap or bumping the stretcher or the bed or something like that. That's a really, from the aspect of trying to assess for peritonitis. Because again, some patients, they just, you know, everything hurts. But then from there, if you tap them, and they're like going, "What are you doing?" And they don't have much going on. Or the other question is, how did you, driving over here? How did you do driving over? Or if you're driving in the ambulance and your partner is going really fast and hitting all the bumps in the streets of Toledo, if the patient's jumping off the stretcher, that's another telltale sign. Murphy sign. This is for from the aspect of cholecystitis. This is really when you take in a deep breath or the patient breathes out. You push your hand up into the right upper quadrant and then have them taking a deep breath. If they jump off the bed, then that's a positive Murphy. Orthostatics. There's a whole bunch of different literature. I still do have it in the guidelines for performing orthostatic it doesn't give you much value for volume status. It does give you some of the other things like for POT syndrome or the neurocardiogenic syncope or something like that. So on orthos, have the patient laying flat, sit them up, and then wait a minute, take the blood pressure and heart rate, have them stand up, take their heart rate and blood pressure again, just as a reminder. If the blood pressure drops more than 20 or their heart rate, the heart rate is a better indicator than blood pressure. Right? When we normally stand up, what does our blood pressure do? Our blood pressure will drop and our heart rate will go up. That's a normal phenomenon just because of gravity and all that stuff, which is one of the questions on Jeopardy last night. Other things to kind of sort of take into consideration, anyone over 30, consider cardiac, females, possible any of the GYN, okay, abdominal, lower abdomen, pregnant, age, they have an ectopic until proven otherwise. Geriatrics, anything can go with the geriatrics just from what we talked before. Alrighty. So we're going to talk about, but we're going to break this down and again into 4 huge categories. So your AAA's appendicitis, bowel obstruction, cholecystitis, cystitis, diverticulitis, ectopic, peritonitis, peptic ulcers, kidneys. This is really, is it inflammatory? Is it infectious? Is it obstructive? Or is it a bleeding? All right. So knowing more of the classifications or the general stuff is really what we're going down for. And again, looking at everything, if you go from the 4 quadrant to the 9 quadrant, this kind of sort of gives you an idea. There's a lot of potential stuff going on there. General management, like everything else, airways, if the person's not breathing, nothing else really matters. I don't care. And then from there, again, make sure that they don't eat or drink, comfort, calm, maintain body temperature. Monitor vital signs, anticipate vomiting, for the advanced EMTs, paramedics, giving them nausea medicine or pain as needed. Cardiac over 30, over 40. The guidelines says over 4, or the guidelines say over 40. But if it kind of sort of looks like a cardiac or something, and you have a medic there with you, get an EKG. I don't care. Okay, it's only paper. And then females, just to reiterate over and over and over again, it's ectopic. ALS, when to call, try to get in getting your backup, tachycardia, hypotension, and then any of your vital signs, postural changes, it just won't go away. So this is kind of sort of what we'll be looking at and broke down and going from there. Any questions thus far? Nothing? Nothing? Alrighty. We're quiet today. I'm sorry. All right. So any of the acute inflammatory conditions, okay? Anything that causes inflammation in the bowel or in the organs and all that stuff. itis, irritation, inflammation of. Okay? You can have autoimmune, you could have blockage, and then from there is different and all that stuff. Swelling, irritations. First one is pretty much the appendicitis. All right. Swollen, irritated appendix. Where's the appendix located? Okay, lower right. Usually it's caused by a cliff or a hard poop that just kind of sort of gets stuck there. There's actually a number of people nowadays that are not even being born with appendixes. Evolutionary it's a worthless thing. A couple hundred years ago, we needed the appendix to help for the breakdown of red meat and all that stuff. Now that we're cooking it, it doesn't matter. Blood pressure causes rupture. So this is the person, the person that you have to be concerned about is they're complaining of right lower quadrant pain. It's cute, it hurts, it looks like an appendix, and then the pain goes away. Okay, those are the patients that they ruptured their appendix, and now they'll start develop peritonitis, sepsis, and death. Okay, all too often we've had bad things happen with that. Early, they get the periumbilical, nausea, vomiting, and then as it starts getting quote unquote ripe, it moves down to the right lower quadrant. And what is that location? What is that point called? McBurney's? Ever heard of that McBurney point? Okay. So McBurney point, what they say it's 1/3 to 1/2 between the umbilicus and the right iliac crest. That's kind of sort of where they say the appendix lies. But it can be anywhere in the right lower quadrant. It could be McBurney's point. Um, People don't always have pain in the right lower quadrant if they have a flipped appendix, if it's laying, vertical, or if it's laying horizontal, going across behind the bladder, or stuff like that. And ultimately, the last presentation is where it's ruptured and the pain decreases, but that's a telltale bad sign. Dunfine sign is pain when you cough, and then from there we'll have a couple others, signs and all that stuff. Sorry about that. Or septicemia, basically infection. They're becoming septic. Fast heart rate, elevated white count, fast breathing with signs of infection. And pretty much treatment for this is fluids. And then nausea control and all that stuff. Cholecystitis, irritation, inflammation of the gallbladder. Okay. So you can have what's called cholangitis, which is bile duct, or the cholelithiasis, which is stones in the gallbladder. Cholecystitis, of course, is the gallbladder, or the acalculous cholecystitis, where you don't have the You have uh, inflammation of the gallbladder without gallstones. Um, Acute cholangitis in elderly patients can kill them very easily. So older patients, right upper quadrant, again, that's one of the major things that we think about. Gallstones are the most common, 30 to 50 in females. So it's the um, 40 female, fat, fertile is the the presentations that they always say and all that stuff. And then from there, fatty foods is a huge trigger. So when you're asking them, when does it hurt, what happened, what's going on, does any food make it better or worse, and all that stuff. They have Murphy sign. Again, what is Murphy sign? We just talked about this. So you have them out, you push into the upper quadrant, then you have them breathe in again, and if they jump off the bed or punch you in the face, that's a positive Murphy. So it's pain if you're pushing in the right upper quadrant. All right, nausea, vomiting, and jaundice, and all that stuff. Fatty meals, right upper quadrant management. Stop. Don't let them, you know, eat anything. Pain medicine, transport, and all that stuff. Diverticulitis. So a diverticula, okay, or diverticulum are the little out pouches. Okay, it's a hernia of the intestines, is what it is. So you have the smooth muscle that's going down the intestines. The wall of the intestine kind of sort of pushes through the muscle and it out and it pushes out. All right. The most common location is the left lower quadrant. You have one? Okay. It hurts. Yep. And that's the next slides. Yep. So the diverticulitis is the inflammation of the diverticula. Most common, again, seen in your 40s, 50s, 60-year-olds. As we get older, that's when we start getting the hernias and all that stuff. Pouches become blocked, fecal matter, seeds, raspberries, strawberries, those sort of things. You're told you're supposed, or nuts are another big culprit. They can have some microperforations and then develop peritonitis and all that stuff. So low fiber diet, diet low in fiber, creates more solid states. Uh, from there, you want to other things that can cause again is the inflammation, the infections, adhesions, scarrings, and fistulas. Those are complications of diverticulitis and all that stuff, or rupture. Abdominal pain, usually left lower. They also might complain of some constipation and diarrhea and all that stuff. Okay. Antibiotics, liquid diet, surgery if needed. Again, not much for you guys to do in the pre-hospital setting, transporting fluids for medics, advanced EMTs, and all that stuff. NPO. Pancreatitis, all right. Irritation, inflammation of pancreas. All right, dude. You suck. All right. Um, the pancreatic duct or Stenton's duct goes all the way down the pancreas. So anytime that this gets blocked, and usually the most common culprit is after infection, you can actually have the gallbladder. A stone comes down and it blocks the end of the duct and stuff. All right. So enzymes can't get out of the pancreas. So what happens? You have a blocked duct. You got a blocked plumbing. Okay. It ruptures and then it starts eating itself. All right. And that's where a lot of the problems come from and all that stuff. Alcoholics, fatty foods, and all that stuff are another leading telltale problems and all that. Suddenly or over months, some people only have one attack, some people have frequent multiple attacks and all that stuff. If it gets bad enough, the pancreas dies completely. They have to go on insulin and all that stuff. Classic, epigastric pain or right, and it goes straight into the back. Now, that is the quote unquote classic pain and all that stuff. Um, Other potential causes, problems, children with handlebars, so they go over their handlebar, ram themselves, and actually say scorpion bites too. Yeah, that's what I had to say. All right, I got these in the wrong spots. Apologize. This is actually supposed to be for appendicitis. So psoas sign, if you have the person lay on the left side and you pull the leg back, that psoas muscles on the front of that, and if it irritates the psoas muscle or they have pain there, that's a telltale one of the telltale signs for appendicitis. The other one is the obturator. Again, the obturator is one of the muscles, so you have the person flex their knee and you rotate their leg in and out. And if the muscles, when you're sliding the muscle back and forth, and if that irritates their the leg or it irritates that right lower quadrant, that's another telltale for appendicitis. All right. So again, two things that we talked about earlier with the bleeding sign, the colon, the gray Turner. So you can sometimes have this with your bad appendicitis and all that stuff, or bad pancreatitis, where they have ruptures. So we get a little bit of the bruising around the belly button. Okay, that's colon sign. Um, is you see that right there? So they get bilateral flank bruising. Okay, that's gray Turner. Okay, they're having a posterior or retroperitoneal hematoma and all that stuff. I've seen this once. Patient didn't make it. Not good. Management again, if it's bad bleeding, all that stuff, hydrations, pain control, and go from there. Right. Irritable bowel disease versus IBS or irritable bowel syndrome. Uh, there are actually a lot of people that are saying now IBS is another form of depression, or a lot of people with depression kind of sort of has IBS. So they're using a lot of antidepressants with IBS versus IBD, which are irritable bowel disease, Crohn's versus colitis. Crohn's is pretty much from mouth to anus, skip lesions, real bad, versus the colitis, the colon, um, that's the inflammation of the colon itself. IBS, hypersensitivities, the pain receptors, they get hyperresponsive to the smooth muscles. Again, some thinking that it's a little bit of a depression going on and all that stuff. Cause constipation, bloating. They a lot of times beginning in the childhood, various triggers. These are the ones that they're just constantly, chronically having to go with diarrhea, belly pains, and all that stuff. Typical ages, they have flare-up symptoms, management supportive, and then from there, a lot of patients over time they become depressed, more depressed. They just don't like life and go from there. Crohn's disease, entire GI. You can have anything from the mouth all the way down to the rectum, anus. And it has areas of scarring, narrowing. They can develop a lot of obstruction as a common problems with your Crohn's disease. Um, a lot of people out there with that. Some they're thinking genetic, some they're thinking immunologic, some they're thinking that it's a environmental. We really don't have a good rationale and all that stuff. Patients, though, from the aspect, they do have the bleeding, weight loss, the chronic abdominal pain. Sometimes they have to have part of their intestines removed, large intestines, small intestines, and all that stuff. So they can have nutrition problems and all that. Pre-hospital is pretty much just making sure that they're volume resuscitated and controlling the nausea and pain and all that stuff. You see your ulcerative colitis, inflammation of the colon. You get the thinning of the intestinal wall. Then from there, they can have again the same thing, similar to like Crohn's disease, bleeding and all that stuff. And a lot of the UC is bimodal, 15 to 25, and then over 55 and 65. Some people do in the 40s and all that stuff. Gradual onset blood diarrhea, okay, the hematochezia, okay, the bloody diarrhea, the bright blood versus the melena which is your black tarry stools and all that stuff. Hemodynamics, give fluids if need be, and then pain control and all that stuff. All right. So we've talked about the inflammatory bowel stuff. Again, anything ITIS, irritation, inflammation of, all right, versus getting into the infectious etiologies. So infectious, pretty much the same thing. The same on the inflammatory, it does cross over. Pancreatitis, you can have some infections. The diverticulitis, some infections. Cholecystitis, some infections, and all that stuff. So there is still some crossover. Problems with the infectious side of it is usually going to be you're old, so we have here at the casino, young, not here at the casino, or something you're immunocompromised, your HIV, cancer, which you could have here at the casino. Okay, and stuff. So anything from the aspect of damage allows for the tissues to be the surrounding tissues to release problems, cytokines, and all that stuff, and then the allows for the body itself to be invaded by bacteria, viruses, fungus, fungi, and all that stuff. Tapeworms can cause problems and all that stuff. Ultimately, sepsis is the process where you have infection that goes from the GI system or any system into the bloodstream. That is definition of sepsis and all that stuff. AGE, this is one of the most common things that we're seeing right now, which is the acute gastroenteritis. So they throw up, have diarrhea. Okay, that's gastroenteritis. All right. So the Norwalk, guys, several years ago on the cruise ship. Okay, remember? Did you hear about the Norwalk bar stuff on the cruise ships? So this is a common thing that we have. The Giardia, okay, with your parasites. So if you go out backpacking, okay, if you don't properly take care of your water supply and you're dipping your water from the streams and all that stuff, okay, you'll probably get a little bit of the Giardia. Cryptosporidium, we kind of sort of this is the pigeons. Pigeons carry cryptosporidium, and HIV patients are really known for this problem. And then into the bacteria, a whole bunch of different things. Campylobacter, Vibrio, which you'll see in the water. This is the cholera that we had that killed a whole bunch of people back in the 1800s because of poor sanitations. And then Shigella and Salmonella. This is boy with the Salmonella. Actually, it's probably been 10 years ago. I'm dating myself. Thank you very much. So anything that causes abdominal pain, diarrhea, nausea, vomiting, that's gastroenteritis. All right. Several hours or several days, depending on their contact. It's infection. It takes time for it to build into the system. So this person's going to have some nausea, vomiting, diarrhea, and then 7 days later, you have it. All right. You have to build up enough of the bacteria or virus or whatever in your system for it to cause problems. Typical from the diarrhea, nausea, vomiting. side of the glands and then turns, you have abscess formations. So we have to know, is it what's called a perirectal, or if it's higher up and all that stuff. If it's perirectal, it's a bad sign because it can track up the rectal intestines and all that stuff. So I've had patients lose part of their colon because of a perirectal abscess. Treatment, pain, kind of sort of figuring out. They'll have some constipation, drainage, and all that stuff. Put your finger into the butt, and then, well, you guys won't. The doctor will. Okay. Uh, okay. Uh, So, pain with defecation, or when doctors put their fingers to kind of sort of they can feel an abscess type mass and all that stuff. All right. Bowel obstructions, pretty much the whole aspect here is you either have a paralysis of the intestines or the intestinal luminal diameter becomes compromised. The most is adhesions in America. Outside, it's more of an infectious process and all that stuff. Adhesions, hernias, tumors are the common. Cramping pain, their belly gets distended. Okay, we've probably all seen this before. They have absent bowel sounds. Okay, nothing's moving, and then if you're palpating, sometimes you can even feel the fecal matter. Small bowel cancer, Crohn's disease, hernias, blockages, and all that stuff. Little kids that swallow batteries. I've had one of the first patients that I took care of a long time ago had swallowed, I think it was like 5 or 6 watches, multiple jewelry. Yeah, he had issues. Yeah, yeah. He came in with a single episode because of vagal and crapped all over himself, and the nurse was pulling watches out of the poop. It was fun times. Crampy, intermittent. They can have some diarrhea, nausea, vomiting with this. The, the a lot of times they're constipated, or they can't have a bowel movement. The other term is called obstipation. It's where they have so much blockage that the fluid in the diarrhea actually flows around the blockage, just like a little bit of a river. So that term is called obstipation. Monitor blood pressure, volume, kind of them from that aspect. Put nasogastric tubes into them, antiemetics. If it's bad enough, then of course they have to go to the operating room to kind of sort of have things decompressed or taken out. Large bowel mechanical, usually they get colon dilation. There's a syndrome called Oglesby where the large bowel, it's an unknown cause for large bowel obstruction, or their large bowel just gets big with all that stuff. Treatment's pretty much the same. Small bowel obstructions, stop them from eating, drinking, putting in nasogastric tubes, and then if need be, surgery and all that stuff. But they have the same type symptoms: the abdominal distension, peritonitis, if they have rupture and all that stuff. Hernias, anything that kind of sort of protrudes out. Many different regions that have hernias. The most common is going to be in the inguinal region, either what's called a direct or an indirect hernia, and that's a lot of it depending on age. The majority of the older patients kind of sort of have an indirect hernia where it goes down through the inguinal canal and protrudes through. You can have abdominal hernias, umbilical hernias, all that stuff. So pretty much the same thing. Different causes: obesity, staying prolonged, straining when you're trying to have a bowel movement, COPD, coughing, or like myself, just unfortunate. Most commons: the gastric, the umbilical, and then the inguinal and the femoral. Again, the inguinal is the most common location for that. Reducible, okay. What's a reducible type of hernia? Okay. Or you can actually push the hernia back in. So they're complaining of abdominal pain. They're saying that they have a hernia, and you take the hernia, and you can push it back into the hole. Okay. Incarcerated. All right. This is where the hernia comes through, and you can't push it back in. Okay. From there, the strangulated. This is the bad one. It's an incarcerated hernia that is actually now blown up. It's ballooned out, and it's has lost its blood supply and its dying tissue. All right, so they can actually lose part of their intestines. And then incisional hernia is just a hernia that's gone through some previous incisional site and all that stuff. Inguinal again from the aspect of protrusion of tear through the inguinal canal. Uh, okay. The inguinal canal from there, again, it has a connective pathway into the peritoneum and all that stuff through the spermatic cord. So the intestines, it loops out and goes from there. If you can't push it back through, it becomes strangulated, which leads to necrosis and death. Supportive, pain management, assessor sepsis. All right. Rectal foreign bodies is always a potential cause. All right. You can either do it from the upper or they can shove it from below. Fletching. Have you guys heard of the term fletching? Fletching. Yeah, that's where they take a paper, a roll of toilet paper, and gerbil. That's that's called fletching and all that stuff. So, assessment rectal pain, defamation. They can. The problem again is with perforation of the rectums and all that stuff. All right. This was a patient from a long time ago. This is a Yankee Candle along with two golf balls. Okay. Don't try to take it out. The problem with this, with the Yankee Candle and all that stuff, you can't get it out. You just, you know, we actually had to take the patient to the operating room and all that stuff. No, they're out. They put the golf balls in first in the Yankee Candle. All right. So different cause of bleeding. Okay. You can have it coming from the top, or you can have it coming from the bottom. Really, treatment wise, is hydration. Establish IVs. If it's really bad, these patients can die quickly on you. You have a ruptured esophageal varices, ruptured, hemorrhoids and all that stuff, or your Crohn's disease where they can have microbleeding and all that stuff. If it's really bad, they can have quick death. Upper, okay. So again, if it's a melena, or if they're vomiting blood, like with the Mallory Wise tears or Boerhaave, something like that. GI bleed, upper GI bleed. This was my problem when I was 16. Throwing up blood and all that stuff. Duodenal ulcers. They've since found a bacteria, Helicobacter pylori, that was a major cause for duodenal ulcers and all that stuff. Large intestine infections, ulcerative colitis, colorectal, older patients with rectal bleeding. It's cancer until proven otherwise, and then hemorrhoids and all that stuff. Again, going back to the esophageal varices. Okay, so if you look at the stomach esophagus, when we talked about that portal canaval anastomosis, So you have the portal veins going into the liver and all that stuff, the naval side of low pressure. You actually have a buildup of the blood, which in turn allows for that to rupture, or the blood vessels themselves rupture. They get the hematomas, and then that breaks out into the esophagus, and then they throw up. So your chronic alcoholics, hepatitis. So if you have not had your hepatitis B vaccination, okay, this is a reason why you should have your hepatitis B, Hep C, Hep A's, and all that stuff. I don't need to know anything about you squirting. Yes, people with varices do have stuff squirting out from the top. Okay. Again, with varices, increase in blood vessels surrounding the esophagus. The blood can't flow easily through the damaged liver, so then it gets into the portal vessels, and all that stuff. They come in fatigue, jaundice, anorexia. What's pruritus? If someone is pruritic, they're itching all over. Okay. And why do liver failure patients have pruritus? Back in some education, you guys today. Okay. It's from the bile salts. Okay. But they can't get rid of the bile salts. They can't break it down or anything like that. So the salt actually gets onto their skin, and that's where the pruritus comes through. The varices ruptures, of course, just come from the throat, dysphagia, they having throwing up the blood, and then shock. Patients can die quickly on you. Management again, treatment, move, aggressive, therapy, and then ultimately we're calling GI doctors and um, doing scopes and bandings and all that stuff. Or they're drinking it from a sippy cup. That's okay. We have to start somewhere. Some people just take a lot later in life to learn how to drink and all that stuff out of a sippy cup. So, so reflux or GERD, gastroesophageal reflux disease. A lot of patients here, um, the again, going back to the diaphragm, if you remember from that, the lower esophageal sphincter or the cardiac sphincter. Okay, it's not a true sphincter. Don't want to know that. So they get for that aspect, the intestine, or sorry, the stomach kind of sort of pushes upwards. That's where again we develop the hiatal hernia. So anytime that you have the acid contacts going, the acid contents of the stomach going backwards, that's where your reflux and the damage. All right, and you can develop what's called Barrett's esophagus, where they actually have a cancer of the lower esophagus because of chronic reflux. Yep. Again, just from the aspect, pregnant females. This is another reasons why the lower esophageal sphincter, it kind of sort of opens. Pregnant females will have the problem burning the chest. Um, the most common, or when you think of classic symptoms, what position do these people usually say that they're in when they start having problems? Yep, laying flat. So they lay flat, then they start having all that. Heartburn, coughing, swallowing, bleeding, treatment focus on reducing the acidity, Pepsid, protonics, all that stuff. But again, you have one of our biggest things if they've ever had anything, make sure that they don't have an MI. Mallory wise, this is just a little bit of the tearing of the esophagus versus Borhaus, which is the complete tear. So it's just the inner layer with the mallory rise gets torn. Usually they've had some periods of either coughing or vomiting, or they swallow something they can't get it out. They have a lot of pressure in the esophagus and it tears, and they get some light bleeding and all that stuff. Epigastric abdominal pain, usually just from the aspect of treatment, is putting a scope down for you guys in the pre-hospital, is transporting and going from there. If it gets bad enough, some of the cardiothoracic surgeons have to go in and cut them open and fix it. So peptic ulcers, it's a little bit of a continuum from anything from gastric ulcers, stress ulcers, duodenals, depending on the time, and then different type of risk factors: stress, alcohol, smoking, and then the Helicobacter pylori, which is a known uh, bacteria causing peptic ulcers disease and all that stuff. So gastrics, if they increase the secretion, so the pain, within a half an hour to an hour, versus the pain 2 to 3 hours after eating, because that's when this is when the acid starts, and then all the chyme gets dumped into the duodenum, and all that stuff. And then we do have what's called some stress ulcers, where you have Cushing's ulcers, which is damage to the brain, or Curling's, which is burns and all that stuff. So this is why we put a lot of patients on stress ulcer prophylaxis in the hospital and all that stuff. Year, months, all that stuff. Just different causes of the most common, of course, going with the Helicobacter, or the erosive gastritis for people that drink a lot of dark colas. Has the phosphorus and all that stuff. You can have the erosive gastritis and all that stuff. Ulcer formations and different treatments, different therapies. Put a lot of patients on care, kind of sort of coats the coverings, and then things that reduce the acid, Pepsid, Protonics, Tums, all that stuff. Left upper quadrant, they get this gnawing sensation. A lot of people actually, if they push in the epigastric with the peptic ulcer disease, it kind of sort of makes them feel better. But then from there, the with it is the disappears after eating, but then returns hours later and all that stuff. Vomiting, belching, heartburn. The problem, of course, is the aspect of it when you have the ulcer formation. Okay, gets down into the subcutaneous region, and that's where all the blood vessels. So the blood vessels now starts having burning or starts pushing through, and they start throwing up blood or they start pooping blood. That's where your melena, okay, which is digested blood, comes through and all that stuff. And if it gets bad enough, of course, there's times that you can actually have the in the stomach kind of sort of, or the duodenum. It burns through the duodenum into the aorta, and you have a fistula, duodenal aortic fistula. When you have a whole bunch of, that's really bad. Hemorrhoids, just anything from the outpouching of irritation, pains, and all that. This is what they kind of sort of say it feels like. Mass, rectum, hematochezia, and all that stuff. Pre-hospital is pretty much just, you know, controlling, supportive management. We give them creams, high fiber diet, and all that stuff. Anal ulcers, this is kind of is a tearing. The most is common at the 6 o'clock and noon, or your upper. Um, a lot of times you'll actually have in the different positions, like with Crohn's disease and all that stuff. Children with anal fissures, babies, you have to kind of sort of take into consideration as for the inconsolable child, do they have an anal fissure as a potential? And then from there, just from having hard bowel movements. Kids with anal fissures, of course, always have to take into consideration of abuse, okay, and to go from there. Painful, defecation, dressings over the anus, don't pack it, nothing like that. Hmm. Any questions on that? Bleeding, blockage, inflammation, infectious. All right. Pediatrics, a common cause for them to have problems. Bless you. A lot of them can have just the vomiting, sodium potassium problems, uh, which in turn can cause other problems. Genetic anomalies. This is gastroschisis, which they have the um, intestines and all that stuff are protruding through the abdominal wall. Um, Wrap this up, put it back in. This is a lot of times seen with your preemies and all that stuff. Um, have intestinal malrotation, where the intestines itself is kind of sort of off into different areas. Um, what's called situs inversus and all that stuff, which is a bad thing. So when genetically or when we're embryologically, what happens is the intestine kind of sort of gets protruded out, rotates and then gets pulled back in. If it doesn't get rotate and pull back in, this is where they get the malrotations and problems and all that stuff. Pyloric stenosis, okay, you get a thick band. The pyloric stenosis or the pyloric sphincter is at the bottom of the stomach. This looks familiar for you. Uh, yep. In the past, they used to cut these kids or cut the babies. So the classic is young males, firstborn, and they're feeding, and then they start throwing up the quote unquote projectile vomiting. Okay, this is the kid that can vomit and it splatters stuff on the opposite wall. Yeah. They can have some bleeding and all that stuff. So what they do is now they just go in laparoscopically and do myotomy, which they just cut the muscle, which in turn allows for the sphincters to open up, and they don't have any problems in later life. Yeah, they now it's not that bad. Yeah. Well, so yeah, exactly. Scale assessment, skin turgors. A lot of this is the kids that they've been throwing up for several days, so they've had problems with the fluid resuscitations, and then getting history from the parents. You know, other things to take into consideration with these kids because they've been vomiting and it's been going across the room. So take into account for stuff like abuse, trauma, and all that stuff. Okay, does the kid have head injury problems and go from there? Um, Gastrotomy tubes. We see this a lot more kids, different problems and all that stuff. It can become clogged, dislodged, and all that stuff, blocked. Um, so from there, it's pretty much you're not doing much with the G tubes and all that stuff in the field. Okay. Do recommend though if you with this take the tube with you to the emergency room. Okay. So often that we get the parents, I'm like, okay, what tube is it? I don't know. Okay, where's the tube? At home. So for us to try to replace it, it really helps and all that stuff. Exactly. Size and type, and there's a whole bunch of different things with that. It was either this or putting the dinosaurs one commercial, the dinosaur one with the dinosaur fart. All right. So different things now. All right. So again, we've talked about the pediatrics, the infectious, inflammatory blockages, bleedings, and all that stuff. So your triple A's, abdominal aortic aneurysms. All right. Anytime the the aortic wall, because there's three different layers to the aorta. All right. What happens is the intima kind of sort of starts breaking, and blood starts getting into the between the intimal and the medial layers, and then ultimately it will go through the outside layer, and then that's where you have the tear and death and all that stuff. So your pulsatile mass, you can actually see some of these patients, their abdomen is pulsating and all that stuff. All right. Again, the biggest problem, of course, is when it gets to the rupture and shock. For they have the exsanguination. I don't know why I can't say it right now. Mesenteric ischemia. All right, any interruption of the blood supply. All right. This is usually with your um, elderly patients, atrial fibrillation. They're not taking their Coumadin. Okay, clot breaks off. They have the embolism and all that stuff. You can also have cancer gets into this problem, thrombus formations, and then of course, anything else, vasospasms. Gradual versus sudden. The big ones, if it's a gradual, it's usually more along the tumors and all that stuff. Sudden onset is the ones that have the atrial fibrillations, blockage, nausea, vomiting. Usually, it's have epigastric abdominal pain, and then the rectal bleeding and all that stuff. Rapid transport, watch for shock. These patients crash on you quickly. Ectopic for the pregnant female. All right. Different locations that the embryo can kind of sort of attach outside the fallopian tubes, inside the fallopian tube. Usually it's in the distal two-thirds of the fallopian tube is the location for tubal pregnancies. There's also been knowns for stuff in the ovaries and all that stuff. So any abdominal pain, you know, in the female, childbearing age, okay, they're pregnant until proven otherwise. All right, and then they are ectopic until proven otherwise. Especially if they have vaginal bleeding and all that stuff. Cirrhosis, different causes, etiologies, and all that stuff. Early liver failure, hallmarked with the portal hypertension. They have problems with bleeding, and then of course they have the problems with the detoxification. All right, so they can't break down bile, or actually the hemoglobin. They can't break down the hemoglobin. So what does their skin or eye color look like? Jaundice. Okay, icterus, jaundice. Weak, fatigue, anorexic, and then pruritus. Going back to the pruritus, they can't break down the bile salts, so that gets itchy and all that stuff. They get they can have the striae and all that stuff. Enlarged liver, turgor problems. They can have what's called spider telangiectasia, where they get the spider veins on their skins and all that stuff. Eyes with the jaundice and all that stuff. So a whole bunch of different causes. They can have their hemorrhoids or even um, the blood vessels in the scrotal region and all that stuff too. Multiple stages and all that stuff. Alcoholic stools, which is the fatty stool, where the stool actually it's floating on the top. It has a nice glycerin fatty stool and all that stuff. Dark urine. The icterus is the jaundice. Uh, yeah. Ascites, the swelling of the abdomen, with the fluid waves and shifts and all that stuff. Supportive, control bleeding medications, and then if you need to, give medication, kind of sort of try to go at the lower end stage because so many of the medications are, degraded by the liver. And again, with these patients, if it's a true liver patient, giving them glucagon isn't going to really do much for them. All right. So, for the advanced EMT and paramedics, if they're a diabetic, they don't have the glycogen stores and all that stuff. Encephalopathy, this is usually a late stage where their liver can no longer break down the ammonia or get rid of the ammonia. And then from there, have increased ammonia, which causes the brain to kind of sort of go loopy, problems with the blood-brain barrier, and all that stuff. Memory loss to coma. They can have other things from infectious renal failure, GI bleeding and all that stuff. Supportive, check blood sugar, transport, okay. Other things to take into consideration, your traumas, your overdoses, and all that stuff. Kidney stones, all right. So what's the classic signs and symptoms for kidney stones? Back pain, okay. So you get the flank pain, all right. And how do you test for one of the tests that you can do? So CVA tenderness, tap on their back. Okay. Okay. Sick minds, sick minds. All right. So hitting on their back, tapping on their back, they get the costovertebral angle, tenderness, and all that stuff. This is the flank pain that radiates around to the front, into the kidneys or towards the bladder and all that stuff, versus the ones that the pain starts in the bladder region and goes, upwards. That's more of your classic of your urinary tract infections with development of kidney infections and all that stuff. Nausea, vomiting, hematuria, extreme listless. The other patients, they have the kidney stone shuffle, but they just can't. It's a they colicky type pain because of the stone is it moves, gets caught, it moves, gets caught, as it's going down the ureters and all that stuff. PID, they have the whole aspect of the pelvic inflammatory shuffle. They're usually get a little bit of hunched over. They do a little bit of a small walking because they don't want to move anything. The whole pelvic region is inflamed. This is your typical chlamydia, gonorrhea, where they have the vaginal discharge and all that stuff. Fallopian tubes become infected and they can have scarring and all that stuff. So the majority of the things that we have um, uh, in the region is a blunt trauma, different causes, crush injuries, compression, deceleration forces, getting ran over, stuff like that, and then any of your closed abdominal injuries. Shearing, just from the rapid deceleration, the organs are still moving forward, and this would be like the intestines that still move forward, and it's kind of sort of tethered to the wall, so things get pulled apart, ligamental trice and all that stuff. This is also one of the or up into the heart region, that the aorta, the same thing that you have the patients that usually die, they have the aortic rupture because the aorta itself is tethered and it can't go anywhere. Bleeding, abdominal bleeding stuff, shoulder pain, hypertension, and think of any of your multi traumas. Crush injuries, baseball bats, getting run over by a car. What was it, the 8-year-old the other day got a hold of grandmother's keys or something, ran over. Yeah, read that in the news or something. Falling objects, you know, that's always a bad sign and all that stuff. Versus the compressions, any of the direct blows, punched kicks, you know, getting hit with the baseball bat again, can have damages and all that stuff. Versus the penetrating, stab wounds, gunshots, um, the gunshots. I mean, that's a several hour lecture by itself on another that stuff. But all the different things of the force impact, going in versus coming out and all that stuff. Just low velocity, medium velocity versus high velocity, kinetic energy. Going through the whole thing of how much damage that you can do. Different contributing things, trajectory, is it going down, up, straight, is it glancing, blows, and all that stuff. And then, of course, the different, single odd versus double odd, and all that stuff versus 45 versus 22, just the bullet profiles. Evisceration is just a term that anytime that the abdominal contacts kind of sort of pull through the abdominal wall, um, and this is how your samurai from a long time ago would, kill themselves if they had problems with their honor, that they would slip their stomach in this. and all that stuff, and then get their head chopped off. Strangulation, we talked about this already from the aspect of the protruding, when we talked about the hernias and all that stuff. A lot of times they do have the aspect of having their knees bent forward, try not to bear or cough down. Impaled objects, never a good thing. Yeah. Best that I've ever seen was a guy that got rebar. He had a piece of rebar stuck through him. He fell. I've seen patients that have, slipped falling on the metal fences, get impaled on the fences and all that stuff. Infection is always a huge problem. Yes, he probably does need a tetanus shot. Liver injuries, anything right-sided, abdominal, fractures to the 7th to 9th ribs, and then the splenic injuries again on this other side of your left side and all that stuff. Penetrating objects versus the splenic. Sometimes the splenic injuries, they don't, 24 hours later. I've actually seen patients several days later come in with left upper quadrant pain because they do have the splenic fissures and all that stuff is a little bit of attachment. Again, blood trauma is the most common mechanism of injury. 9th to 10th rib fractures, left upper quadrant, tenderness, hypertension, tachycardia, and then pain to the left shoulder. Pancreatic, high energies, from the aspect of getting hit into the epigastric region, handlebar injuries, getting punched in the solar plex and all that stuff. Versus dramatics, high speed injuries, not wearing proper seat belts or wearing just the lap belt, you get folded over and then the abdominal contacts get pushed upwards and it tears the diaphragm. And it's nothing amazing on doing a CT scan and seeing all your stomach and intestines up in the chest wall. Difficult to breathe, just to let you know. Penetrating trauma, most common, ruptures, peritonitis, stomach, from the aspect of the stomach ruptures, same things that we talked about, rebound tenderness, rigidity, and all that stuff. Duodenal injuries, same like everything else. The duodenum can't really, it's tethered, so the motor vehicle high-speed accidents, hit the back of a car, things get pulled, gets torn. And then they have, pain and problems, several hours to days later. Same thing with the stomach, the aspect of tearing the stomach, all the acid stuff kind of sort of spills out. Have to go in and operate and go from there. Retroperitoneal, again, this is the aspect of if you have a hematoma or injury. A lot of times patients on Coumadin or blood thinners will have this problem. The colon sign is that the bruising around the umbilicus versus that gray Turner that we saw. Your retroperitoneal hematoma and all that stuff. Any of the vascular stuff, again, high-speed injuries, gunshots, stabbings and all that stuff. Kidney injuries, tackling, football. Not so much. I haven't seen a lot with that, especially with the new pads and everything that's coming through. But a lot of your boxers, MMA fighters, where they're taking the rib shots and all that stuff. Pee and blood, never a good thing. Rupture pain, any of the gross hematuria from the kidney problems. If you get, the kidney slapped around enough, it will swell just like everything else. And then the kidneys breaks the fascia, which in turn have, potential problems there and lose a kidney. Any of the penetrating, getting stabbed and all that stuff too. Same thing with the urinal injuries, just from the aspect of movement, usually from car accidents. A lot of the urinal injuries actually more of complications from, going in and operating, doing other operational procedures that we have problems with the ureters. Bladder from the aspect of accidents, car accidents, and all that stuff. Full bladder. and then having the damage and all that. Ruptured, high mortality rate. Trauma is again the biggest thing. Urine gets into abdominal cavities, and that's it. Questions? Comments?